Thank you for joining us on this program titled Discussing Evaporative Dry Eye, Updates on Diagnosis and New Treatments. It is provided by MedEdicus and supported by an educational grant from Bausch & Lomb. Before starting this activity, please be sure to review the faculty and commercial support disclosure statements and the learning objectives. You can find them linked in the description or on the activity page of our website, courses.mededicus.com. There, you can also claim your free CME credit.
Well, I want to welcome you to a MedEdicus podcast. We are in for a treat with this podcast because we are not only joined by myself, Dr. Leslie Odell, but I have a wonderful co-host with Dr. Lisa Nijm. Lisa, if you wouldn't mind giving me a little bit about your background, that would be great.
Absolutely. Thanks so much, Leslie. It's really a pleasure to be here. I'm the founder and medical director of Warrenville Eye Care and LASIK and a clinical assistant professor of ophthalmology at the University of Illinois Eye and Ear Infirmary. And being a corneal surgeon, I do complex cases, cataracts and corneal transplants and LASIK and everything under the sun. And it doesn't matter what type of surgery you do, the ocular surface will affect your outcomes. So I'm excited to get into this discussion with you today and talk more about meibomian gland dysfunction and how we can improve treatments for our patients and get better outcomes.
Again, it's so great to have someone like you to talk to because I'm on the opposite side in a medical optometric practice where we're doing a lot of general medical care that's non-surgical. So we are always trying to give our surgeons in my area the very best ocular service so that they can have successful outcomes. So I'm anxious to hear some takes from the side of the surgeon. So, the learning objectives with this podcast are to incorporate diagnostic strategies that examine meibomian gland dysfunction in routine practice, and also allow you to better design evidence based treatment plans for persons with meibomian gland dysfunction associated dry eye disease. So, getting into meibomian gland dysfunction, this is something that has really evolved over the past decade. I remember with the TFAS MGD workshop in 2011, it really started to be this paradigm shift in what we were understanding with meibomian gland dysfunction. And also, really, just that when you're grouping your patients in, you're thinking about aqueous or evaporative disease, that a lot of people had combined disease. So now meibomian gland dysfunction is thought to be one of the most common ocular diseases. And we know that this is a big part of dry eye disease. What an exciting time because there's new therapies that are showing great promise at addressing MGD's underlying pathophysiology. And I'm really excited to dig in and discuss the pathophysiology of the disease, but also where our treatments have been over the past decade or so and what these new therapies are going to offer for our patients. Interrupt me along the way, please. MGD, chronic abnormality of the meibomian glands that can lead to changes in glandular secretion, which leads to eye irritation, inflammation that we see, whether that's through point of care testing in the office or maybe through our vital dye stains, and then ultimately ocular surface disease. And you think about, yeah, go ahead.
I was just going to say that I want people to, when they think about meibomian gland dysfunction, to understand that knowing the pathophysiology has helped us design more specific treatments that have really moved the needle, I think, with improving the outcomes for our patients and treating their symptoms. And we know that the pathophysiology starts with, or we suppose that it starts with meibomian gland obstruction that then results in duct system hyperkeratinization, some meibum viscosity increase that increases the melting point of the meibum, which it comes into play with some of the therapies that we have to treat it. And then involves things like microbial infection and inflammation. And that results in what you see clinically with a gland dropout, reduced lipid secretion, and the clinical symptoms of dry eye disease.
I love what you said about meibomian gland viscosity increasing the melting point because oftentimes I think it might be overlooked by the clinician when they're thinking about something like a warm compress, for example. We now have good evidence that shows sometimes longer duration moist heat is needed in more advanced cases of meibomian gland dysfunction. And that has a lot to do with that change in the melting point. So, great summary. This vicious cycle that we've been talking about in dry eye for probably several decades now, at least two, we have this outer loop, if you will, that is looking at how evaporative stressors can feed into what we were thinking of typical dysfunction in the dry eye vicious cycle, which would be the lacrimal functional unit. So, maybe walk me through a little bit, if you don't mind, about how you utilize this double circle vicious cycle in the way that you think about patients clinically and maybe even in how you educate them.
Sure. I think when it comes down to it, when I see all those complex diagrams, I think I have a tendency to just gloss over. So I like to break it down to what we really are seeing in clinic and why this is so important to not separate from your understanding of dry eye disease. And I think what it comes down to is that the effects of the meibomian glands not working properly and having this hyperkeratinization and dysfunctional meibum really triggers the dry eye disease cycle that we're all familiar with. And the processes overlap at each stage. They're both fueled by inflammation, or that at least worsens it. We're unsure of the exact cause or what triggers these events, but we do know that one causes the other to become worse. And unless you find something to break the cycle, then you're going to continue to have problems with patients having difficulty with their tear film, problems with complaints of all the usual symptoms that we associate with dry eye, from sandy, gritty to dryness to tearing, etc. And so I think it's just really important to not ignore the lids and not ignore the meibomian gland examination and understanding of the pathophysiology of that and how that's affecting your patient's clinical signs of dry eye.
And I think that brings us to some really great questions to have for you and I to discuss, which is why do you think that MGD is so prevalent? For me, a lot of my patients, and you as well, I have them in different categories. I have a lot of patients that are on a lot of screens, and we know that there's definitely terminal duct obstruction if you have inadequate blinks. That is going to contribute to meibomian gland dysfunction. I also have a significant amount of patients with rosacea, another big part of MGD. And then there's some great work that continues to come out around all the different offenders that we're putting on and around the eyes, whether it's just a face wash to remove makeup or just clean your face at the end of a day, or makeup that our patients are wearing that can also be offensive to the secretions of the glands. But anything else that kind of stands out in your mind about just why MGD is such a prevalent condition for our patients?
I think you hit it on the head. I think a lot of the lifestyle choices that we're making nowadays with everybody seems to have gone post pandemic to utilizing computers and screens more, myself included. And that we have really strong evidence that shows that over time, we don't have as good a blink when we do that. And I see patients now who are wearing contact lenses far longer than we ever predicted before. They've started when they were 10 and now they're in their 60s. And I definitely think that that has also contributed to increase in meibomian gland dysfunction. I'm glad that you had mentioned rosacea because I do think that is one of the most overlooked causes of meibomian gland dysfunction. I actually had a patient, God bless his soul, he came to me in his 90s, his early 90s, and he had for 30 years, he had secretions and problems with dry eyes, and he had seen several clinicians, and he had florid rosacea. And so the first thing I asked him was, did anybody has anybody treated your rosacea? And he said, somebody gave me doxycycline at some point, but it bothered my stomach, so I never took anything after that. And I said, no, no, we're going to have to find a way for you to take some doxycycline. And so I worked with a dermatologist and we got him on doxycycline, and he complained of mucus and secretions for over 30 years, and they went away with treatment of his rosacea. And I just think it's just such a important overlooked cause of gland dysfunction. I'm glad you highlighted it.
When you think about rosacea, and first of all, I thought you were going to go with The 90-year-old patient said no one has told him it. What rosacea? That's what I was waiting for to say. So I'm glad that along the journey, someone at least thought to try to treat him with
Yes.
some oral antibiotic like doxycycline. The other thing that I'm sure you think about in those patients is Demodex blepharitis, which is a big contributing factor to MGD. The easiest thing that you can do is look at the tear breakup time. So, tear breakup time is going to give you a really good indicator of how stable the lipid layer is. And we know that is a direct result of meibum secretion. That's something that I do routinely on all my patients, whether they have a complaint or not. And I'm sure that you do as well.
Yeah, absolutely. I think that the slit lamp is your best friend and the you're already looking when people tell me, "Oh, I don't like to look at dry eye," or "I don't want to think about that." You are already looking at all the things that you need to. You just need to pay a close attention to a few different features. And as we touched upon already, the gland expression and looking at the orifices and the lids, you can do that right at the slit lamp. I always try to press on the glands a little bit to get some secretion, to just get an idea. Is this more on the toothpaste end of the scale or is it more olive oil like? And I use fluorescein on every patient. I'm looking at the tear breakup time. I'm looking at the conjunctiva. I'm looking at the cornea, which, like I said, I'm pretty sure all of us are doing. But it's just paying attention to some of these little nuances and taking maybe just a few extra minutes to make sure that you're incorporating the right history questions and looking for those findings on exam to make sure that you're not missing meibomian gland disease, where you're not incorporating that pathophysiology into your consideration for treatments of the patient. How do you do gland expression in your practice?
Well, I do gland expression two ways. Like you were just saying, I use it as a diagnostic. So I know what is inside these glands. And then I do utilize some therapeutic treatments that are heat and expression as far as a treatment goes as well. So for me, I do also image mybography on all my patients. Are you utilizing mybography in your clinic?
So that's an interesting question. I have looked at some different mybography devices and we're still experimenting with what we think is what's going to be best for my practice, but I don't do it routinely on every patient.
Oh, well, and one thing that I've learned when I didn't have mybography also is transillumination gives you an idea. Transillumination at the slit lamp can give you an idea if there is some kind of gland atrophy or not. But when you have that image to look at, I've learned that it doesn't tell me the entire picture at all, and expression's always needed. Where it helps me is if there's very few glands visible, which you would be able to detect again at the slit lamp, then I get a little bit guarded about treatments because if there aren't glands to actively open, then maybe that patient's not someone that I want to put down a certain therapeutic avenues, if you will. But for me, expression I do on every patient, whether I see good gland structure or not. And I actually am using that MGE tool that Dr. Korb developed many years ago. And that is standard pressure on the glands because your thumb versus my thumb or your Q-tip push versus my Q-tip push could be different. So that just gives us the standard evaluation of what's releasing with the force of the blink. But I use that also to help me understand if I do a treatment like a thermal pulsation or a gland clearing treatment with IPL, for example, that I use that to see do I activate more glands. So I use it as a diagnostic tool prior to those treatments and also again after I've done the treatments.
So that's really interesting because I do the exact same thing. And I have to tell you, I find there's nothing more satisfying to me than doing expression after I've done a thermal pulsation treatment and seeing just all of that dysfunctional meibum come out. It really is amazing when you start paying attention to those different secretions. It's just you understand you start to see why patients are symptomatic or why they've got problems with dry eye.
So let's talk a little bit through just some of the treatments that are available. And then I actually wanted to share a case of a patient that I had recently with you just to hear your take on it as well. But So we talked through different ways to treat meibomian gland dysfunction. You can start off as simple as things like lifestyle, which could be warm compresses, tear supplements, nutraceuticals. Then you can move to anti-inflammatory treatments with immunomodulators or things like even lifitegrast, because we just talked about how inflammatory this condition is. Depending on the cause of the meibomian gland dysfunction, we might even trickle into oral agents if we needed antibiotics. For example, in our rosacea patients with doxycycline that we mentioned. And then these therapeutics that are treatments in office, whether it's heat and expression or whether it's light based treatments with IPL. But anything that I'm missing on what we have in the toolbox as it is right now?
I would say that all those treatments you mentioned are excellent. And in addition to that, I also utilize punctal plugs. And sometimes I am the bad guy and I tell patients that they have to be on a contact lens hiatus just to give their eyes a chance to recover. And we try to treat and get them back in the contact lens. But I think we have so many options for chronic treatment of dry eyes that what I've found myself doing is moving from artificial tears to prescription treatments a lot sooner than I had in the past. And the other thing that I would say is that I'm also more intentional about the recommendations that I make for preservative free artificial tears because we don't have to rely on insurance for that. And patients can take our recommendations and get the specific ones that we know have quality, high quality components, as well as studies back up their performance. So I think there are many things that we can consider in the treatment of dry eye and meibomian gland dysfunction.
One thing that we both left out of that I just thought when you were speaking to that is lid hygiene and all the different
Sure.
OTC cleansers that we have too, just to help keep bacteria overgrowth and a nice healthy microbiome, if you will, for the
Yes,
contact lens patient and the non-contact lens patient.
true.
But let me talk to you about one of actually someone who's grown to be one of my more favorite patients. She originally came to me constantly bothered by her eyes. She just always blamed it on allergy. We hear that a lot, right? Oh, my eyes bother me, must be allergy. Do you have allergies? Oh, I don't know. They've never formally been tested or know that they have environmental allergies, but it just seems like that is where patients' minds often go when they have eye irritation. So she was just living in this constant feeling of her eyes. So this patient had great vision, 20/20 uncorrected. She had punctal stenosis. So in this case, punctal plugs wouldn't be my first option, although something we can definitely keep in our consideration for patients with evaporative dry eye. She had significant rosacea causing a lot of gland atrophy. So she had marked loss of glands, about 51 to 75% of the meibomian glands had shrinking appearance or atrophy of the glands. And then to complicate things, a little bit of conjunctival cheilitis. She had superior map dot dystrophy, which wasn't helping with her rapid tear breakup times at 4 and 3 seconds. Good Schirmer, though. She was measuring well on Schirmer testing of 10 millimeters or more in both eyes. And then when I looked at the gland function, so again, her structure was poor, but when I looked at her function, she had about 6 glands yielding liquid secretion. So honestly, not bad. A lot of times when I'm looking at my patients, I may have 2 to 3 glands. And
Yeah.
6 glands were moving in the right direction, but my goal is I'm grading 15 glands, so as close as I can get to 15. But science says if I get to 10 or 12, the patient's going to feel a whole lot better in their eyes. But let me just walk you through where I was and where I am actually, because she's in a little bit of a holding state right now, if you will. So I've gone through 4 sessions of IPL with her, and that has really helped to control rosacea for her. She is using the loteprednol 0.25% for flares. And that does help when she is in heightened allergies, but she's actually doing quite well. She's using heat when needed because sometimes, again, heat and rosacea can be a tricky thing. And then, like you mentioned, I do have her using a lipid containing artificial tear because I do agree we've got so much science in artificial tears. But that's kind of where I've had this patient for some time, and I'm really anxious to try some treatments that are newly FDA approved and soon to be available to us in clinic, mainly the perfluorohexyloctane drop that we just recently saw approved. And I'm really hoping that might help me with this continued rapid tear breakup time. So, just an interesting case, and someone, like I said, that's in queue for what's next. But I know that you are going to do a little bit of taking us through what to expect from the trials with the introduction of perfluorohexyloctane. So I'm sure both of us will have a little bit of time to get used to that new word in our vocabulary.
Absolutely. I think you beautifully illustrated the kinds of patients that are going to benefit from perfluorohexyloctane for treatment of dry eye disease related meibomian gland dysfunction. We will have a little time to practice that word and say it fast 3 times. But it is an FDA approved novel therapy. It's got this fascinating dual mechanism where it stabilizes the tear film, but then also enhances meibum flow. It's really like nothing we have currently on the market, which is really fantastic for our patients. And it's just something for me that I think is a blessing in ophthalmology that we always have this kind of push for innovation and bringing in new products that can potentially help our patients. It reduces evaporation by 80% in vitro, which is fantastic, and with minimal effects on visual acuity. We know we have a lot of data on this, not only from the FDA trials in the US, but it has been previously approved for treatment in Europe, Australia, New Zealand. And so I actually have heard about this from colleagues overseas for some time. It's interesting because unlike artificial tears, perfluorohexyloctane is actually 100% lipid. And so it's got this low surface tension that enables it to spread on the ocular surface. And then that's what helps prevent evaporation of the tear film and contributes to increased patient comfort.
I have seen
Yeah.
it, or I've heard of it just like you over the past few years. And it's so interesting that low surface tension and spreadability of this drop that although patients aren't going to hopefully put half the bottle in their eye, but it spreads out that it doesn't, it almost is like they can't feel it, but they know it's there. And I've heard a patient describe it almost like a silk-like feeling to the eye.
Yeah, I think they have a little bit of this cooling sensation and silk-like feeling. The 2 phase 3 trials were Gobi and Mojave, and they were conducted after successful phase 2 trials. They compared perfluorohexyloctane to hypotonic saline, and the primary outcomes were changes in corneal staining and the eye dryness score. There were almost 1,200 patients who were randomized 4 times a day for 8 weeks. And both trials met the primary endpoints with significant differences that favored perfluorohexyloctane. In fact, the total corneal fluorescein staining, the change from baseline to week 8 in both Gobi and Mojave were statistically superior to the control. And then the same thing with the eye dryness score shows statistical superiority from baseline to week 8. And there was really high tolerance among patients with minimal adverse events. The predominant ocular AE was blurred vision in 3% of patients. Patients were using it in the trial 4 times a day, which is really comparable to how often they're using artificial tears. And I think this is going to lead to, just like you were showing in your patient, to be able to treat these patients who are already using an artificial tear, but just not receiving that kind of relief that they want, that they need. And having a profile like this will allow physicians to have a shorter discussion and an easier time getting patients the right treatment for their condition.
I sure hope that's true because the world of prior authorizations and even patient education continues to seem to take more and more time, and time is costing us in other ways. So I like what you're saying, and I hope that is exactly what we'll find.
It's true. We do. We have these great results in trials, and then reality of situation is oftentimes we're dealing with insurances and things outside of our control about how readily we can get these new products to patients. But I'm very encouraged by this data. I think those are excellent outcomes for clinical trial. The data is very strong. The AE is very minimal, and it really presents an entire new class of treatment for these dry eye patients that attacks meibomian gland dysfunction from a very unique angle.
I think that you're right in saying that the discussion with patients will be shorter because it's easy to explain evaporation. It's easy to explain that, especially to our patients that we said are contact lens wearers or are using screens for long periods of time and feel the effects of using their eyes all day. And so explaining that a drop is helping to delay evaporation. And I think that you said by 80%, that's going to be easy because people know what that means, right? They know what evaporation means.
I think that will resonate with a lot of patients, and hopefully it will be available to us, that the rest of it will be easy to get in our patients' hands.
Also surprising in a good way about the data you just presented was from the safety standpoint, blurred vision, although a minimal side effect was the biggest AE. I didn't even hear you say anything about installation site pain. So this seems almost too good to be true when I'm thinking about some of the therapeutics that we have for our patients.
So true. That's a big hurdle, right? We finally get the treatment to the patient, and from the side effects, they don't use it, they don't want to use it, or they can't use it for the length of time that they need to. But I'm very encouraged by the results of the clinical trials.
Yeah, definitely exciting times. It's been a long time in the making, and I'm just glad to have some options almost in reach for our patients. So that I know the both of us are just more than thrilled to have more options available for patients. Give me just sort of a wrap up idea of how you feel about meibomian gland dysfunction and all of these changes in our treatment landscape and how that's going to impact how you can continue to optimize the ocular surface when you're thinking about surgery or just trying to help give your patient their best vision for each day of their life with the tasks of daily living that they're performing.
I think that meibomian gland dysfunction plays a much larger role in our day to day patients' lives than we've given it credit for. I think as we've learned more about the pathophysiology of MGD, we see how affects the vicious cycle that we have learned so much more about with dry eye, and how it can really contribute to patients' symptoms. And I think knowing that, it makes sense then to be sure that we are asking the right history questions, that we are paying attention to the glands on examination, and that we're incorporating these new treatments that can really address some of these problems that we know with evaporation from not having sufficient lipids and from having dysfunctional meibum that's present. So I think that we have a lot of exciting treatments for our patients with dry eye disease. What I said at the onset, I will stick by. I don't care what kind of surgeon you are. If you don't pay attention to the ocular surface, you're not going to get the best outcomes for your patients. So I think it's something that we need to make sure that we are incorporating our evaluation and treatment of meibomian gland and associated dry eye disease into our everyday practice.
And I think you said that beautifully. And I like what you said at the onset, which was you're already looking. So it really, you just got to hone your skills and pay a little bit more attention. And especially with that expression on all patients, you really get an understanding of what is in the glands to better understand why you might be seeing some things as it pertains to ocular surface issues. Great content. I knew this was going to be a lot of fun. Like I said, it's always fun to pick the brain of a colleague and a surgeon like yourself. So thank you so much, Dr. Nijm, for joining in. Really, we encourage everyone to keep a lookout or a listen for some upcoming podcasts. There will be some more real world case discussions of MGD and a focus on new and emerging evidence based treatments. So be sure to be on the lookout for that. And thanks so much for your time.
Thanks for joining us today.
To receive your free CME credit, complete the questions and evaluation via the link in the description or on our website, courses.mededicus.com. There, you can also contact us for suggestions and feedback on our programs. Thank you for listening.